Hi everyone, my name is Martijn and welcome back to the 6th episode of the Sunstar Conversations Pro webinar series. Thank you so much for joining us today and I hope you're all doing great. Just a short recap for those who are joining us for the first time. Now, for the past few months, we have been discussing several oral health challenges across different life stages. Kicking off the series with pregnancy and periodontal disease back in March, we have since then tackled caries prevention during childhood, orthodontic treatment in teenagers, dentin hypersensitivity during young adulthood, and behavioral change in middle-aged adults. All very interesting conversations with stellar speakers, packed with information and tips and tricks. So if you want to watch those back, visit and subscribe to our YouTube channel, Sunstar Global. When you're there, don't forget to hit the notification bell so you will be the first one to know once we publish a new video. Now, before we start, just a little housekeeping. If you have any questions, you can ask them in the chat function on YouTube. And if you're watching from the Eventbrite page instead, you won't have this option. So you have to click on the Watch on YouTube button on the left bottom corner of the video screen, which will take you then to YouTube. So let's dive into today's episode, in which we have reached the elderly life stage. Now, with life expectancy is increasing, which is one of the main reasons why the number of elderly people worldwide is increasing as well. And this, of course, goes hand in hand with the rise of certain health challenges. And the one we will discuss today is frailty. And as always, we will do this with two experts from the field. First, I would like to introduce you all to Professor Martin Schimmel, who is chairman of the Department of Reconstructive Dentistry and Gerodontology at the School of Dental Medicine at the University of Bern in Switzerland. Hello, Martin. How are you? And are you also looking forward to today?
Hi, Martin. Thank you for the invitation. I'm very much looking forward to the conversation with Professor Tsakos and the questions from the audience.
All right. Yeah, that sounds good. I think we have a lot to talk about. So we will be back with you in a minute. First, let's introduce the second speaker of today. You already mentioned him, Professor Dr. Georgios Tsakos. George is professor in dental public health at University College London in the United Kingdom, and he's chair of the Platform for Better Oral Health in Europe. Hi, George. It's very good to see you again. How are you doing?
I'm doing fine. Nice to see you again, Martin. Very much looking forward to discussing with Martin and you and reflecting on the views of the colleagues and people that are watching this.
Good. So do I. So let's bring Martin back into the conversation. And as I mentioned, today we were talking about the concept of frailty. I would like to begin by setting the stage and to define what exactly is frailty. What do we mean when we talk about frailty?
Well, it's a nice way to start because there isn't a simple definition of frailty, actually. There's a number of definitions and concepts, and if you like, manifestations of frailty. If I was trying to put it in one sentence, I would say is a syndrome of older adults that is related to probably reduced physiological reserve and increased vulnerability to internal and external stress factors. There are many different definitions, and the one that has a lot used in the literature comes from about 20 years back. It's the one that the original paper was by Fried, I think, and colleagues, that they said it's a clinical syndrome where you have three or more of a list of not so nice things to have, like unintentional weight loss, feeling exhausted, feeling very weak, your hand grip strength being low, walking with a slow speed, and having low physical activity. So if you think about all those things that I've been describing are very physical in terms of the phenotype of frailty, in the process, this has been quite more sort of enriched, if you like, with a lot of colleagues talking about accumulation of deficits over the life course and looking at the number rather than the nature of disabilities and conditions, which also include some interesting I would say more cognitive elements as part of frailty. So there isn't one solution fitting all in the frailty literature, but it's fair to say that no matter how you measure it, so either with only physiological or physiological and cognitive elements, and I would very much support a phenotype that has different elements as well, and there's also environmental aspects of frailty. It's a whole debate. Practically what it means that it's a condition where it's an important condition of older adulthood, quite prevalent. I mean, the studies vary a lot, but we're talking on average about more than 10% of the old adult population, and very much linked with going down, so sort of downgrading of the function, both physical, cognitive, and linked very much to, other comorbidities and mortality. So I don't know if that sort of gives you an overall idea. It's a broad concept, but I know, and Martin actually is an expert on this, that there has been even aspects in the definitions talking about oral aspects of frailty as well.
Yeah. So as a dentist who treats elderly people, very old people, geriatric patients, of course, this concept of frailty entered this specialty of dentistry from the geriatrician side. And of course, if you recognize a patient who is frail from a medical point of view, you will see the patient will be weak and will be probably dependent on care, or be on the edge of being dependent on care. Will also have like general symptoms, or cannot come to the dentist anymore. These are more general aspects. But of course, this frailty then has a impact on oral health as well. The ability to clean teeth, to prepare a healthy meal, and so on. And this is the one aspect. And the other aspect, what we also want to discuss today, is this new concept of oral frailty. Well, the topic of this webinar today, and I just want to maybe give you where does it come from? It doesn't come from out of the blue. So first, I heard this or read this in the program of the IADR in San Francisco a couple of years ago, where suddenly Japanese researchers had presentations with oral frailty, and of course, frailty, this is really this attracts a geriatric dentist. And we went there, and in the matter of fact, this concept of oral frailty, or this idea, comes from Japan, where dentists are historically more involved into not only caring about teeth or oral disease, but also very much are involved into oral function, and to a degree that in a dysphagia treatment or team in Japan, there will always be a dentist who does part of the diagnosis and also of the treatment. And then it really came into light of a larger, let's say, audience, academic audience, this concept of oral frailty, and its brother or sister is oral hypofunction. In this way is a position paper published in 2018 by the Japanese Society of Gerodontology in the journal Gerodontology, where they actually define, as they have developed it in Japan, this concept of oral frailty, who is a pre-stage in this concept to oral hypofunction, as they call it, and it's basically a decrease of oral function, and this is, of course, something then that's very interesting for someone who cares about, who as a dentist for elderly people, because less and less, there is the problem of gum disease, of caries, and so on, but this ultimately leads to a decreased function, and as an outcome of all this oral disease, or sarcopenia of the chewing muscles as well, decreased occlusal force, this was a very interesting concept. And this position paper from the Japanese Society of Gerodontology actually described how this diagnosis actually entered the healthcare system as a diagnosis in Japan, with certain thresholds of certain parameters, and these are decreased tongue function and lip function, decreased tongue pressure, decreased occlusal force, as they call it, or chewing force, and then poor oral hygiene, oral dryness, then also decreased masticatory function and also swallowing function. And then now this is how this came into the world of dentistry, also then now here in Europe. Yeah. And of course there are, it is very interesting because as dentists, we treat oral disease and only start really caring about oral function, oral fitness, let's say, as opposed to oral hypofunction, and because this function in the end then will, besides the low-grade inflammation of periodontal disease maybe, will have really an effect on overall function, also on frailty.
And if I may sort of intervene on this, it's also interesting because we are talking with the same more or less terminology, but with concepts that are not exactly the same. So if I look at it from a public health perspective, well, my starting point would be, I'm a dentist, but I'm a public health dentist. I like epidemiology and public health. I think it's important to look at the broader picture as well. So while it is quite important to look at the sort of functional aspects around the mouth, it's also very relevant to see how the mouth fits with the broader picture of frailty and healthy aging. I mean, to put it into context, the World Health Organization has called the next decade from now until 2030 as the decade of healthy aging. And the emphasis at last shifts also to include not just what we traditionally were doing, younger populations or younger adults, but also older adults. Now, there's reasons for that. The reasons are, of course, the demographic transition, but also the epidemiological transition. And in oral health, we have an even more dramatic transition towards a high needs older age cohorts that coming now. Is what we call in the UK the heavy metal generations, which are people of my age and the ones that follow hope they're better, which differently from our fathers and our mothers, we hope to live longer. No one knows yet, but that's the trajectory. And we live without edentulism, more or less. I mean, they're still there, but it's much less prevalent than in the past. So we have natural teeth in our mouths, and we're going to hopefully keep them, or we need to keep them for very long to have a good function. So the emphasis on healthy aging comes from all sorts of angles, not just oral health, but health in general, because it's how you participate in the society, how you maintain a good level of oral health to have your social roles intact and not having disability, having a good quality of life until very late in your life. So I think with that context, it's very important to think how oral health links to what the overall frailty, because it also consists of cognitive aspects, environmental aspects. Yes, the physiological and the functional are very, very important. They are not the only one. It's not just physical function. There's also cognitive function there. So I think both concepts, the ones we've described, are relevant. I find it personally a little bit confusing because one is called frailty, the other is called oral frailty, and people may think, oh, it's more or less the same, but in the mouth. Well, no, the story is a bit more complicated than that. And I would think that the emphasis on the overall frailty and how oral health is affected by it, but also affects it. I think Martin said in the beginning, how do you care? As a dentist, as an oral health professional, how do you care for a frail older adult? That's not necessarily something that my generation was taught in the dental school. It was taught the technical aspects of it, but there's other aspects of the care that, the curricula need to be updated, if you like, to care for that population. And not the dentists that are coming through, but already our colleagues that working now. How do you care for a patient that needs to maintain a functional dentition in older age and is frail? It is a challenge. I think it's a important clinical challenge, but I think it's a public health challenge as well. And we can discuss it in detail. So I think that's an important issue, an important take-home message. It's not just only how oral health affects frailty, which is my personal primary interest. How oral health is important part of healthy aging, and I think it is, and we have a lot of evidence to show it. It's also, when you are frail, how do you maintain oral health? How do you care for those vulnerable groups of older adults?
Mm-hmm.
Yeah, George, I totally agree that there's a danger in this term oral frailty, let's say, because we might confuse it with frailty. And I'm not a big fan of this term. I would call it decreased function or hypofunction or something. But of course, this does not meet the criteria by the Japanese society. But I think we still need to discuss. But I totally agree with this. And the other thing you mentioned, and it's good to talk like this, because me as a clinician, you as a public health professional, that we basically on different levels talk about the same thing. Like if you look at this healthy aging by the WHO, as we wanted, of course, there's also great opportunity for dentistry to get closer to medicine again, to not be as artificially separated from medicine. And there's a huge opportunity to become more medical. And you probably agree, George, that the main burden of dental disease, oral disease, will be or is already in the elderly population. And it's steadily increasing. And this is, of course, something that I see in daily practice as well. And I'm fully convinced that we as dentists need to address the issue that our patients become older, and that in general, and that the workload of what we have to do will be probably very much concentrated in the elderly population or in the elderly patients we have. So we need to, there is a real need, and I think this is also the topic of this webinar, that we need to be aware that in the elderly population, in our elderly patients, there is much more than drill and fill and taking a tooth out. We need to have the full picture of the patients, be it polypharmacy, multimorbidity, how the logistic aspects, how do they come actually into our practice? Can they really go to twice a year to the dental hygienist? How is this organized on an individual level? And these are things we need to address and organize. And then something, if you there's a very nice statistics also from Japan, how you see that caries increases with age, the prevalence of caries or incidence of caries with age, the incidence of periodontal disease kind of stays the same over the lifetime, but then starting at age 60, 70, the complaints about loss of chewing ability rockets, and we as dentists, we usually don't address this problem because we're not aware of this. We did not learn this in dental school to address this, but this is becoming really important in elderly patients to address this functional issue. And then, of course, treating elderly patients I call now their practitioners, the medical practitioners, much often than before, because We have common interests. Patient loses weight, patients can't eat anymore, or has gum disease, bleeding from the mouth, pain in the mouth. And this is something that's also aware to the practitioners, to geriatricians as well. And here we come into this situation as dentists that we need to become more medical to address the full picture of the patient, and especially in frail patients.
Yes, that's absolutely. I mean, that's spot on. I agree on all of what you said, actually, Martin, because we have to think also that the systems will not be able to cope with the traditional model and ways of working, thinking about the aging societies. The reason I called my generation as a heavy metal one, that was a strange title given when we realized that those 45 to 60 are the ones that have the natural teeth there, hardly any edentulousness. Unlike in the past, if you went to the national statistics in many European countries 30 years ago, a good proportion, a considerable portion would be edentate. And once they become edentate, there's so much literature to show that the perceptions change, the expectations change. They tend to diminish sometimes. So our cohorts and the next ones expect a good quality of life for many years to come, and rightly so. It's a fundamental human right. What they expect is not something bizarre. And they come with many natural teeth, many of them heavily restored. That was one of the reasons they were called the heavy metals, because it was amalgam at the time. It was so you open a mouth and it's full of amalgam restorations. Now they're gradually being changed to something less metal, if you like. The other reason, to joke a little bit, it was because that cohort coincided at some point in the sort of early teens or early adulthood with affiliation with a heavy metal band. It was very popular at the time. So there were heavy metal in the ears, heavy metal in the mouth. That's why. But if you think about them from a systems perspective, this is the group of population, and it's a big one, that you cannot just simply treat away as per usual. They have complex restorations. They want to maintain function. 60 to 70 will be the crucial decade, and that will be shifting as we go. It will be older and older. And they expect and deserve a good oral condition so they can live a healthy life. So it is not about thinking how I can maximize things, but it's about also thinking from a public health perspective, how can they maintain a functional dentition? How can we make sure they have enough number of teeth in good condition to be able to chew well, eat well, but to also socialize? And so it's not just the function as physical function, it's also the social and psychological function. Now, that's one aspect of the things. I would say what has helped us with the healthy aging agenda is that it coincides with, all of us know now, the current World Health Organization resolution on oral health, that actually the global strategy, the draft global strategy, talks about a life course approach, talks about aging populations as well. So the oral health community understands that we have to go hand in hand, putting the mouth back into the body. It isn't a better group to do that than the older adults. It is an opportunity, really. And if I was following the life course approach, and I will say this and stop, I would say as a public health professional, it is about focusing earlier. There's no point waiting for people to become older and say, now we have a problem. Mm-hmm. If we want to avoid having a problem generation after generation after generation, we really need to make sure they come with good oral health throughout the life course. They follow a trajectory of good oral health, of limited or no oral diseases and good behavioral patterns. So in essence, the healthy aging agenda for me is an agenda that doesn't say, oh, you're under 50, I'm sorry, I'm not interested in you. It says, I am, because I know you will be part of the aging agenda. It's looking at the totality and exactly putting the mouth, as I say, back into the body, looking at the health team, the oral health team. And it's interesting, Martin mentioned, can we send them to an to a dental hygienist for twice a year? In many countries in the world, we can't, because the oral health workforce doesn't include something like that. Maybe, covering the needs of the aging cohorts, we also need to think, what does this mean for the workforce as well? Where do we go from there? What is the role of the dentist of the future? How sort of leads and coordinates a team of oral health professionals, hopefully, maybe, particularly in a certain context. But I know I'm opening now different questions from the one you asked, but it was really interesting to say, how do you maintain, how do you care, and how do you maintain for those people?
Yeah, I'm just picking up the line here because there's some very interesting research approaching lately how you can ensure like an adequate oral health in homebound people or in people dependent on care. And there is this like consensus that we should like brush our teeth perfectly twice a day. And we still come from this perspective and approaching this group of patient dependent on care. And then we always get frustrated that this is not happening and that the caring workforce cannot do this. So actually, if someone is in a nursing home, they don't even dream of that their mouth is cleaned twice a day properly. And here in Switzerland, there is an oral epidemiologist who actually also works on patients since many years, Dr. Mengini. You probably have not heard of him. It's a very Swiss phenomenon, Dr. Mengini. But he really went in the canton of Zurich. He went into the nursing homes and said, okay, it's not possible that for what reason, for various reasons, the barriers are too high that in the people living here, teeth are cleaned twice a day properly. And then he said, okay, let's be realistic. There's a specially trained dental assistant, not even a dental hygienist, coming once a week, brushing their teeth. And he showed, he showed that this already had a significant impact on oral health, something we basically do not dare to say. But now there's research coming out from the University of Cologne from Dr. Barbe and Dr. Nowak, Professor Nowak, who actually do some very good research like randomized controlled trials and who actually show that we might need to reconsider these concepts we have of oral hygiene, which I personally think come from pediatric dentistry or preventive for normal older adults, that we need to find new concepts there. Otherwise, it's not doable in terms of workforce. And this was the one thing I want to address. And the other thing you mentioned, and again, this healthy aging, and I really want to make the point here that is a question often arises if I give lectures and they say, okay, if you can't clean the teeth, if everything is inflamed, why just don't you take all the teeth out, put full dentures in, and that's then okay, it's clean. And I just really want to make the point, and you mentioned it, George, that edentulation, that's really the final stage of oral impairment. Dentures are prostheses. This is like a wooden leg or something. And I think no one of our listeners who are probably oral healthcare professionals have a full denture in their mouth, because then they would realize no proper function whatsoever can be achieved without teeth. And that's really, it's an achievement that we have in this older population. Now we have many people who have their own teeth, who still can sense, who still can have a stable function, who can maintain muscle force. And this is only possible with their own teeth. Not even implants can achieve such a level of function. And this is, and it kind of frightens me if I sometimes see how easily teeth are taken out.
Yeah, exactly. And that's almost the dentistry of the past, isn't it? When I mean, I tend to tell my students sometimes that edentulousness is mortality. For our world, for the oral health world, is the equivalent of mortality, really, more or less. So this is the last stage you want. So if I told you that your outcome is mortality, you want to avoid that. So you really want to avoid total tooth loss. And we are in a position, if you look at epidemiological trends, that this will happen. We will observe this in our generation. There will be hardly any prevalence of edentulosness. Now, this is a cause for celebration, of course. This is nice. At the same time, it's a responsibility because it doesn't finish there. And I agree fully that the issue is how you make sure they maintain good function. And you mentioned, Martin, you mentioned what can happen in a care home environment. Now, this is where you see frailty in abundance, really. And different countries try different things, but at least it happens. Something happens. You mentioned the example of Switzerland. In the UK, in the last few years, where it was something completely neglected, the oral health of all the vulnerable older adults in care homes, now we have a guideline from NICE. We have the Care Quality Commission saying something needs to be done. We're doing research to see how can we implement some elements of that. And it is about engaging with a wider group of stakeholders. So we also have the same problem that you cannot assume that you can provide care, send a dentist all the time to do whatever needs to be done and make sure someone brushes the teeth for them, because sometimes they need help to brush the teeth, or many times they need help to brush the teeth properly. Then maybe this is something we can work with the care home staff, train the care home staff, and this oral hygiene is part of general hygiene. And in some cases, we have examples that this works. So it is about the oral health world understanding, and we do, and we have many examples. We have examples from other countries in Europe as well, where programs happen, and in other countries in the world. But we are the exception. In many parts of the world, nothing happens. And I think we need to not forget that this is not a problem of the developed world, it's a problem globally. And it requires sort of shifting the emphasis. That's why I mentioned the WHO resolution and global strategy that talks, for example, about prevention throughout the life course, that talks in terms of oral health, basic oral health being part of the universal health coverage. So it brings issues to the fore that will deal with vulnerable groups, and frailty represents a vulnerable older adult group, people being frail. So I think we have to learn from these initiatives, and there's something to learn from one another. There's an issue of best practices, if you like, because these things do not happen necessarily as a global plan, but colleagues in different parts of the world have very good initiatives. You mentioned the care homes example. It's the work in Switzerland. It's the Herodent program in Belgium. It's the Smart Care Matters. There's so many, the 1,000 Lives in Wales. There's programs after programs after programs happening, and we have a good learning we can do from that. But that's the care homes. I think the emphasis should be also how we make sure people do not go there. What happens with the majority of the people before they become frail? And oral health plays a role on that. And we've been looking at analysis of big longitudinal data sets, so the same people followed over time of all the adults, and oral health markers are very good indicators, very reliable indicators of frailty further down the line. So the literature has up to 5 years of follow-up. We very recently, one of our PhDs is doing some really good research on a 13-year follow-up. And you see that people that their oral health goes down at one point in time, later in the life course, they become frail. So we also have a role to make sure they maintain good oral health. And if we see something going down, then maybe it's a sign of alert. We need to ring the alarm bell and say, oops, this patient in about 10 years' time might be really going downhill. So it's not just an oral health issue, it's a health issue.
If I may, what are these signs that you mentioned that might trigger a professional to recognize these signs? What type of signs are you talking about in that case?
The most obvious one is excessive tooth loss. You don't wait for someone to become edentate to alarm yourself.
Yeah.
In the past, all the surveys we had data, are you dentate or edentate? Fine, but you can be dentate with one tooth or two teeth, and you can be dentate with 32 teeth. It's a very different scenario. You can be dentate with a few teeth and a partial denture or not. So under the dentate category, there are so many different tribes, if you like, different groups of dentate. So when we have data, in more refined data that looks at how many teeth you have, not whether you are dentate or edentate, then you almost see a dose-response relationship. So it's important to get the idea of maintaining the dentition early. And when you have signs of losing teeth, that is probably someone that goes in, has a chance to go into a bad trajectory, not just for oral health, but possibly also for health.
Mm-hmm.
That will be a crucial, I think, if there was one take-home message for me, is make sure you maintain functional dentition.
Yep.
That's essential.
And then you're talking in terms of prevention, of course. Going to the audience of today, who maybe already have to deal with a large group of patients who are already in a state of frailty. What are the things they can do now? Is it a reversible condition? Are there ways they can treat it? Can they train those subjects to sort of get a bit of oral function back again? How does that work?
May I?
Sure.
Just your discussion just before. We have in Europe, we what we do classically, we see how many teeth are lost. We measure gum disease or caries and things like this. And one thing I want to mention, this is also coming, well, it's known in the academic world in Europe for quite some time, but really on a larger level, coming again out of Japan. These are new instruments that are usable by dentists, or functional, very easy devices actually, that can be used, for example, to measure tongue pressure. That's just a little balloon, the tongue presses against the palate, and you have certain values there, and you can actually also from these more functional or chewing efficiency, you have a piece of gum or some measures, glucose extraction. It's very simple tests, yeah, where you can look at chewing efficiency, and these are very good predictors as well for frailty later in life. And this is something I personally advertise also for more use in Europe, because I think these are very good indicators. If teeth are lost, this is already a little bit late. What can you do if teeth are lost? Regain function, your question. Of course, I think still dental implants are something that provide better function than edentulous, like removable prosthesis. And they are, but this is really in the early stages, as I feel it, training, like we do for like if someone like strength training, we know is very beneficial for overall health and also prevent frailty. They start to emerge some tests from for oral training as well. There are, for example, little rubbers of different hardness where you can actually train your chewing muscles back, or increase coordination of your orofacial structures. But this is really in really early. But then also, if you have dentures, and every clinician who will ever have done a new denture for a 90-year-old will know he will most likely not adapt to that. And there are really research approaching how can we help those people adapting to this new situation and achieve a better oral function. Yeah.
And as we go in on how to think about the sort of people with frailty, probably we were talking before about care homes environments, for example, and there we tend to think it's number of teeth, but it's not just number of teeth. Caries is not a disease of childhood. Far from it. If you look at the global burden of disease study, the most prevalent condition worldwide is caries in the permanent dentition, not in the primary, but caries is prevalent until late in life, and root caries is also an issue. It's a major issue. You might think, well, is this really an issue when you have all these other comorbidities? Yes, it is, because look at the evidence on how much impact it has on the quality of life of people. And you want decency and living the last years of your life in as good quality as is possible. Now, is there something to do to prevent it? Can you work in terms of diet? Can you work in terms of oral hygiene? Yes, you can. There are other ways of doing it. For example, groups that have sort of more at risk of caries and root caries, that you can sort of prescribe high fluoride toothpaste, or talking about care homes, work we're doing with colleagues in Northern Ireland and in Wales, looks at how much the diet plays a role in that, and what can be done to influence the diet in a care home environment. That is a very interesting story, because from one hand, we want to reduce sugar, and our partners in this, which will be the geriatricians, they might want to increase it to give energy, because they have the issue of the energy drop, and they want an easy boost, if you like. So it is a complicated picture, but there are things you can do. So by looking at someone that is a frail individual, you just don't just leave them be there, but it is also how you approach them, how you manage them, and that's not something we know from our dental training, how a caring approach and having time to deal and go beyond the fix of the tooth may make a difference. You might discuss and you might say that this is not part of what a dentist should be trained to do. Well, that's a separate discussion. I know that these people need to get care, and they deserve to get care, and they might not be, or they won't be an easy population to say, yeah, sit down, open your mouth, we do it as it was before. So it requires patience, it requires a different approach, but it results in them having back the decency, and that's not something that I take lightly. I think it's an important contribution.
I think we just got a question that nicely fits into this things you can do for this vulnerable population. And it says, what are your thoughts on the use of silver diamine fluoride in this population? So I presume as a preventative measure to prevent caries, for example. What are your thoughts on that?
Well, there is. This is something that is proven quite effective in reviews and in studies. there are many countries where it's not available in this form. But the studies show that this is actually a good thing to prevent. It just should, like, really, well, it's nothing you should use in abundance because it tends to make your teeth black. And but as a measure in frail older adults, well, this was proven in several studies and also systematic reviews that this is a very effective agent.
Thanks for answering that question in between. I think when I look at the time, we're already 45 minutes in. So I think we come to sort of the take-home message. Well, what would be the take-home message you would give the audience? What we've discussed today. Who wants to have a go?
George switched off his mic. So
no, I whatever. Go ahead, Martin.
Well, for me, the take-home message should be, I think I use also a little bit what George said, the information. Start prevention early in life, prevention of tooth loss throughout lifetime, so you have a functional dentition in the older adults. We know elderly adults have a higher quality of life, a better function with a non-functional dentition. This means no removable denture, not even a partly removable denture, have 20 teeth. And this is like on a nutritional aspect, quality of life aspect, and functional aspect, really the goal that we should aim at as dentists.
I see you nod in approval, George.
I fully agree. And the only thing I would add is to say probably the picture is much more complicated, but I don't want us to complicate it more, because we need to do the basics right for this age group and for this vulnerable group, and that will be already a big contribution. Then we can think about all the others, but maintaining a functional dentition, keeping your teeth, would be, if I had to choose one, and start early, exactly as the inequalities agenda says. If you want to sort of prevent inequalities later on, start early in life, put the people in a good trajectory. You're doing them the world of good throughout the life course, not just when they're younger.
I think that's a beautiful end to the discussion of today, I would say. To everybody who's joined in, if you still have some questions, you can always put them in the chat, and we will try our best to answer them after the webinar. We can always get in contact with you. I want to thank the speakers of today. Martin, it was a pleasure talking to you. Thank you so much for your insights and for your lively discussion. And of course, the same for you as well, George. It was great talking to you again. So thank you so much.
Likewise, pleasure.
Thank you. It was great.
And as always, also a big thank you to everyone who's joined us today. Don't forget to subscribe to our channel to stay updated, of course. You can also find us on Twitter, Facebook, and Instagram at Sunstar Global, or visit our website, sunstar.com and sunstargum.com. We will be back next month on the 7th of October with a special episode on caregivers and how can you, as oral care professional, support them to ensure optimal oral health for the ones they care for. So that nicely fits into the topic of today, of course. Keep an eye out on this channel. Thanks again, and catch you all next time. Goodbye all.
Bye. Bye-bye.
Bye.